We have our Dean of Students and Community Affairs, when I say we, Academic City University, who is our guest speaker for this afternoon. However, she's speaking with the hat of the founder and CEO of StratMed Innovations, which is a health tech innovation hub focused on developing locally relevant health solutions. So the work at StratMed Innovations really fits directly into what we're trying to do with the Bio-Innovation Center, making her an ideal speaker for us this afternoon. I'm sure there's lots that we can learn from her session. Now, she brings cross-sector experience, not just in health research, but in finance, in the innovation space, and she's held quite a number of roles, more recently being with University of Ghana Medical Center. She was with the Ashershey Entrepreneurship Center as well, also a facilitator with Design Thinking Ghana, and a fellow of the Chartered Institute of Leadership and Governance. This is the modest version. If you want to name one, just Google her. And so without much ado, it's a great pleasure this afternoon to invite Dr. Abena Engman as a guest speaker for today's session. Emoji round of applause, please. Thank you.
Yeah. Thank you, FC. Thank you very much. And I'm super excited to be here. It's interesting how I'm actually a banker by profession, but I'm finding myself in the health space. Um, so I want to say thank you to the team for having me here. And I also want to say that I have um, my team here with me, my biomedical engineers. Like I said, I have no background in biomedical engineering, but I have a passion for health innovation. So Lois is on the call, and I think Duji is also here, and they are biomedical engineers working with StratMed Innovation. So thank you all. And we're also at the Bio-Innovation Conference that happened last year at Academic City University with our phototherapy device, and we actually won an award for it. So that's also pretty exciting. So I will jump straight into the presentation, and then we'll talk a bit about StratMed and what we do and see how far we can take the conversation. So I believe a lot of us on the call have heard about the Embrace Infant Warmer. And this was introduced in India in somewhere in 2011. But the story actually started somewhere in 2007 at the Stanford School, where a group of students, a group of participants were in a class called Designing for Extreme Affordability. And what they found out, what this particular team found out was that in India and Nepal, a lot of the babies were, preterm babies were dying. And it was not because incubators were not available in India at the time, but it's because they were super expensive. Around 2007, the incubator costs around $20,000, and that was quite expensive. So they did a bit of digging to see what could they do to ensure that these preterm babies do not die from hypothermia. They went around, did a bit of research, and they realized that some of the rural clinics actually did have some of these incubators, and some of them had been used as filing cabinets instead of being used to save these babies' lives. And I want to read a statement that one of their team members made after they had done their research. And what they said was, what we needed was not just a lower cost version of what exists today. We needed something that could function without a constant supply of electricity. Something that was easy enough for a mother, a midwife, a healthcare worker to use. Something that would stay at a hospital, but could also be used at a village clinic. And one of the cultural things that was happening was that when you give birth to your baby, you could also not leave the baby at the hospital. You had to bring the baby back home. It was not culturally acceptable to leave your baby at the hospital. So eventually, to cut a long story short, they came up with the infant embrace baby warmer, where they hit a sheet of wax and was able to keep the baby hot for about 8 hours. Another example is the ultrasound machine that was developed by General Electric. So these ultrasound scanners failed in China because they were too expensive. About 90% of the hospitals in China would not afford these medical devices. So what a local team of General Electric did in China was to produce handheld ultrasound machine at just 15% of the cost. The interesting thing is that that device became so popular and sales reached about 278 million in 2008 from these handheld devices developed by a local team in China. So I am bringing these examples to help us see how existing medical devices have been repurposed for certain clinical settings, certain clinical environments that can help still improve healthcare delivery. And today's conversation is rethinking clinical outcomes. Now, the question though is that, is there even a market for medical devices in Africa? And yes, there is a market for medical devices in Africa, because the interesting thing is that the African population is about 14 to 17% of the world's population, and yet they carry 25% of the disease burden. That 25%, 50%, approximately about 52% do not have access to proper medical care because of the lack of appropriate devices that can be used in their clinical settings to save lives. So yes, there's a market for these medical devices, especially in our part of the world within Africa. Now, the question is, why should we actually even rethink designing our medical devices? Now, we do a bit of research, or let's say a lot of research, as we develop our medical devices, and I'll come to what we've been able to do so far. Now, the medical devices that are developed that come into our part of the world assume that there's stable power. We assume that there are people who can actually repair these devices, who can service these devices when they break down. It's also assumed that there's a stable supply chain of consumables and spare parts and whatever is needed to run these machines. And I always remember a presentation that was made during one of these consortium meetings that we had, and it was described as a graveyard of medical devices. And it was mainly because the supply chains were not as good as it was thought to be. Either they are available but too expensive, or they are not available at all, and hence the machines can't be used. We have frequent outages, and it is assumed that when these machines come to Africa, they can't be serviced, they can't be repaired. But the reality is that we have power cuts, we have challenges when it comes to maintenance. Most of the clinics and the hospitals that are not in the urban areas do not even have biomedical engineers that can help service these equipment. And the truth is that the cost of these equipments are quite high. Like I said, the incubator was costing $20,000. I checked the price of the Firefly incubator, phototherapy machine, and it's about 78,000 Ghana cedis. So when design assumptions fail, patient outcomes fail. And I just want to give an interesting story about boreholes, showing that when the assumptions are wrong, the outcomes that we are expecting, we do not get them. So there's this story that goes around about boreholes. There are about 4 different versions of it, and I'll try to run through quickly. So there's a village that needed a borehole. So an NGO, a company decided to drill boreholes in the particular village. Now, the mechanism was that children needed to play around the borehole to be able to produce the water. And there were a lot of children in the village. So the company assumed that once we get the children to play, it will get the engines moving, and whatever needed to be done for the water to come out will work. So it meant that if the children were not playing, there was no water. Eventually, the project failed, the borehole was not used. Another story about a borehole was that there was a village where the women needed to walk quite a distance before they could get water. And the women actually used that to converse, to catch up on stuff that had happened in the village. Now, the company thought, okay, we'll drill a borehole that is close in the middle of town so that people don't have to walk long distances to get the water. Now, they drilled the borehole, and people were still not going to fetch water from the borehole. When they did their research, they realized that no, we like walking that distance to go and get water because it gives us opportunity to talk and to catch up. The other borehole also failed because the mechanism was such that you had to ride it like a bicycle to get the water out. So the men in the village looked at their woman and said, I don't want to see you by that borehole, riding it like a bicycle to get water because you'll be shaking your waist. So the women stopped using the borehole. The last story about the borehole is they built it behind the king's palace because they thought once it's by the king's palace, it is a better option. The king can get water easily. Once again, people refused to go and fetch water from there because they said they cannot gossip behind the chief's palace. So the borehole was the solution. But then the assumption was that wherever we built it, people will access the water, but the outcome failed. So the story about the borehole is just to say that we need to think about our assumptions whilst we are designing our medical devices, because otherwise the outcomes that we're expecting for our patients will not happen. So the question is, how do we actually start rethinking? And it starts with the context, some of the examples I have given. So with most medical devices need power. The question is, what happens when the power fails? We have to ask ourselves, where are these devices being used? We have interacted with a lot of clinics, both urban clinics, rural clinics, big hospitals, teaching hospitals, tertiary hospitals, and we realized that each of the medical team had different needs for the device, where it's being used, and what it was being used for, and when it was being used. The other question is, does it actually simplify the workflows? The medical devices that we are building, does it actually simplify the workflows or it makes it more complex? The other question is, who maintains it? When this medical device is purchased, who actually maintains it? Are there biomedical engineers available? Are there other engineers who can handle it? So when you want to start rethinking the medical devices that we are building, like the incubators, they said they needed something that could work in the hospital and could also work in the village, because it was highly unacceptable to leave your baby in the hospital and come home without your baby. So where is it being used? Hospital and the village. Is it easily maintainable? So the embrace warmer can easily be cleaned and maintained at home by the user. So devices must adapt to the environment where the care is being delivered. Now, who are we? StratMed Innovations. We are basically a health innovation and a research organization. And our focus is on developing medical devices for low-resource areas. Realize that there are about 61 district hospitals and about 6,500 CHIP compounds. So there actually is a large market for medical devices for low-resource areas. We want to build not just for Ghana, we want to build for Africa. And usually our challenges are quite similar. We build, or we hope to build, medical devices that can easily be repaired, that we have the spare parts easily available. And the most important thing here is that we co-design with the clinicians. We don't assume and just build, but we go back to the users and find out what works for you and what doesn't work for you. So that is how we design at StratMed Innovations. And what have we done so far? When we started, we are actually thinking of quite some complex medical devices. We actually thought of a device to help with vein thrombosis. But after we did a little bit of research and digging, talking to doctors, talking to nurses, doing some observations, we realized that we better come to a level and develop devices that would be needed by clinics and medical personnel that are working in low-resource areas, because it was a real challenge. We also realized that there were rising asthma cases and the COPD burden, the chronic obstructive pulmonary disease burden, was also increasing. And nebulization is required quite often by asthma patients. I realized that even on our campus here, a lot of the students misplaced their inhalers, and then they would have to rush to our clinic to get nebulized. And we also found out that most of the nebulizers are either broken or they are highly dependent on electricity. So if you don't have electricity, you cannot use your nebulizer. And we also got to know that most of the nebulizers used in the pediatric care got broken down quite often. So what were the assumptions, or what did we build our nebulizer on? So like I said earlier, the nebulizers that are on the market mostly have to depend on electricity to use. What we have built now is rechargeable. And when we say rechargeable, it means we use batteries, and you can charge it just like your mobile phone using a Type-C charger. And just use it like when you're using your mobile phone. Once it's charged, anytime you need it, you can use the nebulizer. We also built our nebulizer such that it is durable. Like I mentioned, we realized from the research that we did that most of the nebulizers break down very frequently. So we have built something that we believe is durable. There's also high downtime because of the frequent power outages, and also because people are not there to serve the nebulizer. So once it's not working, we push it aside and go and buy a new one. Once one is not working, we push it aside and buy a new one. So we are building a nebulizer that we can service ourselves and also have the spare parts that need to be replaced once a nebulizer is not working. So that's the difference between the StratMed nebulizer and the ones that we currently have on the market. Now, once we built the nebulizer, we asked ourselves that the assumptions that we had to use to build the nebulizer, is that something we can apply to other parts of the health sector? So we said, yeah, we can apply that to neonatal care, and that's how come we built the phototherapy device that we displayed at the Bio-Innovation Conference. And it is also built such that it is rechargeable and can be used once there's no grid. One of the things that we found out was that most of the clinics that are not in town or in the urban areas had just one phototherapy device, or they didn't have it at all. And some of them were actually built out of wood. And the tubes that were used were not LED lights or blue lights. They were just normal fluorescent tubes. And the wood sometimes gets rotten and making neonatal care very challenging for jaundiced babies. So we decided that let's build something rechargeable at low cost that can be purchased by district hospital, CHIPS compound, peri-urban area hospitals. So the Firefly, like I said, is about 78,000 Ghana cedis when I checked this morning. And we are trying to build something at minimum the cost, even though we are hoping that it will go down further. Yeah, so I've talked about this one already. So our design model that we used for our nebulizer, we used that same model to build a neonatal jaundice device. Currently, we haven't worked on the prototype again because we are pushing all our energy, all our efforts to get the nebulizer onto the market. Currently, we are about to do our clinical evaluations for the nebulizer and then go back to FDA for the other regulatory approvals. We took our first prototype and we got the certificate of analysis, and we are asked to go and do the clinical evaluation, which we are currently working on. And hopefully by the end of the first quarter, we should have been able to finish our clinical evaluations and then continue with the FDA applications. Now, at StratMed, what do better outcomes mean? It's just beyond the device just working. It's being effective and delivering what it's supposed to deliver. We also think that how operationally reliable is the device that we have built. Can it be used? Is it robust enough? Can it be used when there's no power or there's inconsistent power supply? We also think about equity of access. We don't want to build devices that are so expensive and cannot be accessible or affordable to a lot of the population. And we also want to build devices that are sustainable. For how long can we build these devices at a low cost or at a cost that is reasonable so that we can scale beyond Ghana, beyond just West Africa, but countries how sustainable is our model? So if we say better outcomes, we think about these four things. Is it clinically effective? Is it reliable? How many people can get access to it? And for our own operations, is it sustainable? And is it also sustainable for the clinics and the hospitals that will buy it? Now, how the devices reach the patients matter, and it is a whole process. What we learned was that when you are doing your engineering and design, and you're doing your clinical evaluation and your usability testing, you need to think about ethical things and regulatory things right from the start. Yes, you want to build for low resource areas. We want to make it as cheap as possible. But then you also need to think about the regulations that surround the building of medical devices. So you look at all the ISO documents, which ones your design falls into, and is it clinically medically acceptable? The material that you are going to use, it is cheap, but is it medical grade? So as we are building these devices, we're also thinking about ethics and regulations, and not just the fact that we are building cheap things for low resource areas. And documentation is also very important. What we realized was that we needed to document right from day one, because when you're going for your approvals, they will ask you what iterations you have done and why did you change what you changed when you changed it. So when we are developing the nebulizer, when we're developing the phototherapy device, we incorporated ethics and regulation right from the start, and we started our documentation right from the start. And that has actually helped us with our clinical evaluation process that we are going through right now. And we are going to do that alongside the usability testing. So documentation is very important. And we are doing it against the ISO standards and any other standards that are required for medical device development as well. Now, why does this opportunity matter and why is it urgent? It's because our medical systems are overstretched. I had the opportunity to work at the School of Public Health for 5 years, School of Pharmacy and School of Nursing at the University of Ghana. And through that, I got to know how our health system is actually overstretched and the things that are happening. Now, the cost of imports are very high. Now, the CD dollar rate is better, but we all know it's not going to stay the same way. It's going to go up again. And I heard on the radio this week that even though the dollar rate is better, the cost of clearing has not gone down, so the prices of goods are not really going to go down if the cost of clearing the goods is also not going to go down. So the high cost of imports also calls for us to see what we can do within our own system to develop these devices for our medical system. Now, the rising disease burden, like I said, 52% of Africans carry the global disease burden. And there's also growing local capacity. Now we have a lot of our students going into biomedical engineering at the university. So there's capacity to actually develop our medical devices to the standards that we need and what will help improve the medical care that we provide in Ghana. Now, a bit of how we do it at StradMed Innovations. How did we go through the process of designing the nebulizer, the process of designing the phototherapy prototype that we have? So our focus is on the human being. We think about the nurse who is on night duty. We think about the caregiver who is managing asthma of a loved one at home. And then we also think about the patient who actually is going through the asthma. So we think about all these together and think about how can we solve the problem for these three people. Medical innovation or health innovation is challenging or interesting at the same time, because sometimes when you're thinking about it, you don't know who you are solving the problem for. Are you solving it for the hospital who's actually buying the device, or you are looking at the end user, or you are looking at the parent who is buying the device to use for the child? So what we do is to focus on the human beings and listen to them. We are also very curious. We ask a lot of questions. And I always remember this story about my second son when it comes to obnoxious curiosity. When he was young, he used to talk a lot. And one of the days I said, you know what? I'm listening to the news. When I finish listening to the news, then I'll listen to you. And he goes like, Mommy, you have two ears, one for the news and one for me. And he kept on talking. And as Stradmid, we just keep on talking. I mean, we talk to our doctors, and when we start talking, I say, oh, okay, thank you. Then I go back, so I have one more question. Because the answer that he gave, I've thought about it. I said, no, I have to ask. But your curiosity will unlock answers to help you develop your device. We have done so many iterations on the nebulizer. I've actually lost count on how many iterations that we have done, but those iterations have come out of the questions that we constantly keep asking. So we are very curious. We are also very mindful of the process we are going through at any particular point in time. Are we learning? Are we building? Or we are testing, we are piloting, evaluating? Because if we are not mindful of the process, we end up coming back. If we don't learn and we just start building, we still have to come back and learn. So at any point in time, we ask ourselves, why are we printing another prototype? Why are we building something else? If we are not sure, we go back and we learn. So at any point in time, we are very mindful of where we are in the process. And we also embrace a lot of experimentation. We use our prototypes to think and to learn. We build prototypes to test the airflow, to test the battery life, to test how durable it is. So we do a lot of experimentation with our prototypes. We also show our prototypes to our stakeholders, to the doctors. We just don't talk, we show because it's easier to show. And sometimes you get very hard feedback, but when you come back and you think about it and you realize it's actually very true. And we also inspire ourselves. We never forget to inspire ourselves because the journey is actually very hard and very difficult. When you think you have nailed it all, the airflow is correct, and then you go back 2 days later and realize that you have missed something. But we constantly remind ourselves of why we are doing what we are doing. So we use words like we are piloting, we are co-designing, we are co-designing with our clinicians, we are learning just to ensure that we are all on the same page and encouraging ourselves. And we also love to teach. We never miss an opportunity to teach. And one of the reasons why StratMed was also set up because we realized that a lot of the students who couldn't go to medical school said, okay, then when I'm done, I'll go to medical school. And how beautiful biomedical engineering is and what they can do with it, even in medical school. What can you do with it? So we talk to our clinicians, we talk to our students, and we build the innovations together. So that's the process that we have used as StratMed so far to do what we have done. Thinking for us is not just a buzzword, it's how we make sure medical devices actually work where they are needed most. Have you faced challenges? Yes, we have faced challenges. Obvious challenges is financial challenges. But challenge is also the procurement of the parts that you need to actually build these devices. You go on the website to go and procure a part. You do get it. You go there 2 weeks, 3 weeks later, and they say it's out. That's one challenge. The other challenge also is 2 or 3 weeks ago, we procured a part. And when the parts came, we went to go and clear it, and it was costing 1,000 cedis to go and clear the part. So the actual thing we needed was 2,000, but clearing it alone was 1,000 cedis. So procurement of parts has also been very challenging. Now, sometimes you also rely on the networks that we have. But the interesting thing is that the networks that you have and you think they are going to support you are the networks who actually do not support you. But this developing of medical devices is a lot of relying on networks as well to support your work. Because like I said, you need to iterate. You need to make sure that the devices actually work where they are needed most. So the financial challenge is there, but the other challenges that we have faced are also procurement and not getting the needed support from the networks that you thought you get the support from. So, saying in ending, when we want to redesign outcomes, we need to think about redesigning the devices first. Once we rethink the devices of where are they going to be used, who is going to use them, how are they going to use them, when are they going to be used, then we can get the outcomes that we are looking for. And like I said, just like the borehole story, our outcomes become better when our assumptions are better, when our assumptions are on point. Now, the Embrace Baby Woman team thought that even if we build the incubators at a lower cost, the people still will not be able to use it because they can't carry it to the village. And because of irregular power supply, the incubators cannot be used. So that's how come they came up with the Embrace Baby Woman. So it is very important to get our assumptions right from the beginning before we design so that we can actually have our better outcomes. And the last one is if we rethink who designs the devices and for whom, outcomes improve the design. Thank you very much. And this is how you will find us when you are looking for us. So if you scan the QR code, our contact details will pop up. Thank you very much. That's the end of my presentation.
Excellent. Emoji round of applause, please, for Dr. Engman. And thank you so much for that practical and insightful talk as you shared the Stratford journey. I promise you were in for a treat this afternoon, didn't we? But anyway, the floor is open for any questions that you may have for Dr. Engman, please.
Hi, can I jump in and say a couple things?
Please go ahead.
Hi, Abena, that was great. It's wonderful to see what you're doing, and I absolutely applaud your efforts. One of the things that I'm sure you're doing that I think you might want to emphasize a little further is that local sourcing of devices. Not only does it provide you with a real understanding of where they're going to be used and the context they're going to be used, and the repair and maintenance. It also gives you a local source of expertise for training people to use them. And you didn't really make use of training, but we're academics. We think about training, and I think that's also an important aspect of devices that are actually being made in Ghana, locally close to where they're being used, is you've got that source of expertise that can help train people and make sure they understand that whatever is being used is calibrated, something like that. So I think that's something you could even, I'm sure you're already doing it, but I think you could emphasize it as another advantage of what you're doing. The other thing is, of course, the economic sustainability, and that's one that we all struggle with. And and I just want to point out that what we're trying to do with Academic City is to develop not just expertise in interacting with the physicians, but maybe develop expertise in terms of interacting with entrepreneurs who have the business acumen to start finding ways to commercially sustain what we're doing. Uh, because commercializing, um, as foreign as that is to me, really, I'm convinced it is the way to have the greatest impact because that's the way to get things not beyond the prototype form into a scalability that can have really broad impact. Uh, those are my two comments. I think they're great. I'm really excited to see how things going in the future, and I hope you'll be a part of this partnership for a long time. Thank you very much.
Thank you, Lee. Thank you for the comments. And yes, the training is actually part of the long-term plan. So thank you for emphasizing that, especially when it goes beyond the peri-urban areas. The training is very important. And then commercialization is actually a very long journey to take. And we have started thinking about it already, even though we are just doing the clinical evaluation now, but it's been part of our conversation. So thank you very much for that.
That's great.
Okay, questions. You may, put your hand up or me to speak or put them in the chat or comments.
I have lots of questions, actually. So I'm Mark Fuller. I work with people at Academic City and people at Northeastern. We've prototyped a lot of devices, but you have done things that we still struggle with. And one is, so once you try to start putting these in use, you have to start dealing with regulatory. So I'm wondering how you've developed a relationship with the regulatory people in Ghana. And so Lee's already mentioned the other people that we need to are the business people in Ghana. So there are people who are making devices like the Firefly. But I think to really be successful, and I'm wondering, have you, what you've done so far is trying to network with people who might manufacture these devices in mass. And I think if we do that, they may help with the regulatory. So it's part question, part I'm just looking for your take on how you plan to move forward with these things.
Yeah. So when it comes to regulatory, we've actually started the with them. And like I mentioned, that's how come we sent the nebulizer and we got the certificate of analysis. So like I said, it's the network building from my past days working at the University of Ghana College of Health Sciences that we use to build that network to be able to start the regulatory process. And we are trying to keep that relationship warm. And that's how come we are now doing the clinical evaluations. Now, when it comes to networking with people and getting people to help you with the production of the phototherapy device, we actually started conversations. And the interesting thing that happened is that when you start talking to them, oh, we do sell some of the phototherapy device. Do you want to become a distributor? And then I said, no, that is not what we are looking at. We are looking at building. But we recently got into an accelerator, and we hope to be introduced to people who it's not just for the funding, but also to get people who actually want to partner. Because what we are actually selling is not just the devices in isolation, but a whole system of where we do assembly different medical devices, do the training and repair them here. So that's the story that we do sell. That is not just the phototherapy and the nebulizer, but it's a whole system that we are planning to set up. So that's what we've done so far.
Thanks. That's, I mean, you're a lot further than we are. I have one more question. So the Embrace device, I've looked at something like this. I don't know if it's the same thing. Is this a device where there's a material in it that has a melting point that's close to body temperature and you heat it up by boiling? Yeah. Okay. Yeah.
Yeah.
So the one thing you didn't say, and which I'm familiar with, is the clinical trials that had to be done to get this device approved. That's a major effort.
Yeah. So they actually started the process in 2007 and it wasn't introduced until 2011. That's how long it took. Yeah.
Yeah. And I don't think people appreciate the amount of effort that takes.
Yeah. Stratmed actually started in 2022 and we are now in 2026. So it's really a long journey and sometimes it can be lonely. Yeah.
Yeah.
Thank you.
You have to have a lot of patience. Thank you.
Great. Are there any other questions? Okay. I'm just going to say, Dr. Engman, thank you so much. I've made the mental notes as to why, staying curious is super essential in these spaces. And I don't know how you haven't been in any of our classes yet. And so we'll be coming your way. But I'm
There's
going to
a question. There's a
there's
question
a
over
question in the
here.
chat.
Yeah, there's a question in the chat. Yes.
well, we couldn't
Jacob,
join.
go ahead. You can read it.
Yeah.
It's the
So
framework.
from Pascal Matthias says, my question is there a framework for entrepreneurship in the healthcare space in Ghana that Stratmed had to follow? Is there also a laid out channel or steps to follow in the healthcare entrepreneurship space? So it's on the chat section.
Okay. So As far as I know, there's no framework. But I know Ashesi University does have a health track that they run with a university in the US. I've forgotten the name of the university. But as far as I know, there's no framework for health entrepreneurship in Ghana yet. And is there a laid out channel or steps to follow in the healthcare entrepreneurship? Okay, so that's basically to say, yeah. Not that I'm aware of.
Okay. I have a quick question. Well, a question about power. Everybody knows I love solar. So is this rechargeable by solar?
We are thinking about it, but in our first iteration, we are just doing the Type-C charger where you can just charge it with your mobile phone, like your mobile phone, and keep it for a number of hours.
And
The
then the
solar
second question.
aspect
Oh, go ahead.
will
Sorry.
come later.
Right. And the second question is this. Can you have pass-through? So it's plugged in and it's working, but it's also charging, or it can only work when it's fully charged, like battery alone, or you can have pass-through power.
No, you can use it whilst you are charging it, or you can use it after you've charged and unplugged. And you can also charge it with your power bank.
Oh, great. All right. Thank you for putting solar in.
Thank you.
Any more questions? Well, whilst we're thinking about questions, and do keep them coming, I'm going to hand over to Dr. April just to he made his introduction earlier on. He can also share a few words about how you can stay plugged in with the consortium. And then we'll take the final round of questions and call it an afternoon. Dr. April.
All right, thank you. I greet everybody. And thank you, Dr. Engman, for this insightful presentation. You know, the interesting thing is I never knew about you and your group until we visited UGCM, you know, and they were directing me back to someone at my own institution, you know. And so it tells me one thing, that we need to be, you know, communicating. And this consortium is one of the ways that we get to know what we are doing. And in a way we can collaborate and excel together. So my own is, we should look at this consortium beyond just, you know, building a community, right? It's beyond a collaboration. And I foresee that if we are able to leverage on our individual opportunities, resources, and the talents that we have, then we can, we will be able to deliver within the shortest time. And so I'm going to urge that institutional reps who are here should get ready to prepare for monthly updates, because one of the things we can get to know is to give institutional collaborators the opportunity to briefly talk about where they are. I know after the expo that we had, there were a lot of exciting ideas, but we need to keep on pushing each other so that when we are going, you know, to have another expo this year, we would have had some kind of guidance or support from this consortium that will make things better. So I encourage that people should at least participate in every consortium meeting, get your team, and don't just be here alone. If your technicians are supporting, if there are other departments like the business entrepreneurs who are all supporting, they should be part of this call so that we all understand and benefit from each other. So that means that I recommend monthly progress updates from where we are so that we can all build together. And I'm also looking at it that we are not looking at solving one individual problem, but a cross-institutional problem. So that means that we should be able to leverage. Either we co-supervise or we co-advise, especially we have students who are working on projects. And I foresee the possibility that we can have, you know, from different institutions, students working on the same project as we are already doing with Northeastern University and Academic City. We should extend that to other consortium members so that we can use the expertise within the group to advise the students and to get them, you know, deliver. So I also believe that in-person trainings are very important. And usually we organize this towards during the expo. And so we should always take advantage of those going forward. But for us to really keep together, first, we need to know the leadership of the individual institutions. I believe through the what do you call it, the MOUs, we at least received from some few, and we can use those as the channels to know who is the leader in those. But to some institutions, and up to now, I haven't gotten that information, and I believe the MOU is very okay to help us really bridge and know what we are all doing together. But that notwithstanding, one can still be a member of the consortium without an MOU. But I believe it is good to have at least something binding us together. So those who are yet to return theirs, I would urge that you should do that so that we can actually be able to, move together as expected. So I look forward to us, having more collaborations, especially even in joint manuscript writing. We can write manuscripts together, and if out of this consortium we have some paperwork coming out, that will also be another way to refer to, especially refer sponsors to those work that we've achieved together. And I believe that there's no limit to what the benefits of the consortium will be. Thank you. FC, I'm done.
So I'd like to say something on this. This is
Okay.
Ruchi from University of Houston, from Houston, Texas. It's a very good point you brought up here, the joint manuscript writing. This is something I would be interested in too. I have approached a couple of professors and doctors in Ghana for the joint manuscript writing and for the case study cases. And I'm also working with the students here in Rice University and University of Houston for working on especially designing the biomedical devices. One of the device which I came across recently was microscopy screening of hematological diseases, especially in the countries or in the West Africa. So I can share the details with you. And I found that device very innovative. They have kind of filed the provisional patent for it. It's a very innovative device which they have come up with, and they would like to see if that can be, used in the country. It's a low-cost device. They have presented recently in one of the conference here. We are also working with other students here, developing different kind of devices, low-cost device for the countries in Ghana or for that kind of environment. So it would be great if we can collaborate and share our findings here with the students over there, and probably if they can work together in order to improvise those devices better to incorporate that in the real environment.
Great. Thank you very much. That is really welcoming.